Hey guys, welcome back to today's club. My name is Marcos Prevalaris.
I'm Steven Nograti. Today we're going to be doing cervical chair adjustments and setups for C2 through T2. Okay, so the cervical chair we can do anywhere up from the occiput all the way down to maybe T3, T4, depending on your skill level. But today we're going to focus on C2 and down to T2. Okay, so the big thing with those segments is that there's a lot of different things that, systemic wise that are correlated with those. So we're going to say the parasympathetics are going to be typically from occiput down to about C5 is going to be the lowest level that we're going to say parasympathetic. So our sympathetic system, the highest level is going to be that C6. So C6 all the way down to L4, L5 is going to be our sympathetic system. Okay. Also, a big emphasis is the C6 through T2 to T3 area is a big innervation spot for the thyroid. So we see a lot of like visceral issues and body chemistry issues that have to do with the thyroid.
And exactly like Steven just said, this region is responsible for so many things that the body has to see. So something as simple as an inferior C2 or a very anterior C2, C3, that can directly affect the vagus nerve just based on simple anatomy and where it's sitting. So you can get systemic, just like Steven said, issues all the way around the body. You also see things like heart innervation and heart function coming from upper dorsals and also the upper cervical. So you can see all these different things. And again, the foundation of T2, T3 can directly cause hypermobile upper cervical segments. So what may be an upper cervical symptomatology problem is probably coming from a lower cervical or upper thoracic subluxation that's holding up all of that and making the rest compensate. Another great thing about the cervical chair is the cervical chair and prone, which when we went over last week, the prone adjustments for the cervical, these are the only two ways you can truly correct all three planes of motion of a misalignment. And that is compared to the other ways that we see in chiropractic some of the times. These are the only two ways that you can get complete resolution of inferiority, posteriority, rotation, and a wedge on either side. The other ways that aren't in the chair and exactly prone the way we kind of discussed last week, those other ways are going to be missing certain aspects of the misalignment. So that specificity to how the bone is misaligned is exactly what makes this adjustment get so much better results, because you're able to correct the full entirety of the misalignment. Okay, so let's jump into it. Okay, so what we're going to start by talking about is the patient at the right height for what you're trying to adjust? Okay, so what's right for my height and what's right for Steven's height is going to be very different. So if I'm right here adjusting a C7, this is a little low for me. I'm not able to get my elbow down enough to go through that displane line. But for someone like Steven, this is pretty good because all he has to do is drop that shoulder and now he's able to get that displane line. So having the patient set up for your exact adjustment is very, very important based on the height. So if you come around here, you can see the way our cervical chair is designed is the block is facing that way, and it also allows for it to be upright, angled down, or even angled this far down. That can help for an occiput atlas, but we're not going to talk about that much today. We're just talking about having the patient seated correctly. All right, so the first thing that we always have to keep in mind to have a successful cervical chair adjustment is the displane line of the vertebra we're going to correct. So I could turn it this way so everyone can see it. If we're adjusting C2, if you look at this displane line, it's going this way. So for us to properly set the bone on top of the disc, which should be the goal of every adjustment, not to just rack the facets, we're trying to put the bone properly seated on top of the disc. And that's why we adjust the way we adjust. For us to do that, we have to go over these facets right here. As you can see, that angle is like this. So for us to get over that angle, our line of drive needs to be that way. So that's why if we're doing a C2 adjustment, you'll see our elbows are much lower. Okay, as opposed to say a T2 adjustment, you can see that displane line is straight, if not angled slightly down. But you still need to get a little bit of lift to get over these facets to set the bone on top of the disc. But knowing these disc plane lines are very important. So you can see C2, C3, C4, C5, C6, C7, T1, T2 starts going down. So knowing your disc plane line is directly proportional to how good of an adjustment you get. It's not just about the noise you make, but it's about how well do you correct this misalignment. In the Gonstead world, we always are searching for the G note, and that is a loud, deep thunk on one vertebra. When you hear that, you know you're putting the bone on top of the disc because that's the sound a disc makes. When you hear that is facets racking, and that doesn't mean you're getting any proper correction of the P to A and I to S when you're doing the cervical chair. Okay, so the first thing of knowing your disc plane line is absolutely important and will never ever be something you can forget when adjusting in the cervical chair. All right, so what we're gonna go over now is our contact points, which most people should know at this point for the advanced club. But when we're contacting a PL or a PLS spinous contact, we need to know that our contact point is right at the inferior lateral part of that spinous, okay? So we're using this part of our finger to be right there. So when I'm setting up here, I'm tissue pulling up past the spinous, then rolling my contact in, and that is as much of the vertebrae that I'm touching. I'm not doing this because that's gonna get too much body rotation and not enough P to A, I to S movement. So I'm going to be putting my contact like that, and that is all that is on that vertebra, okay? So if we're doing a complex listing where it's a PRI, we are not all the way out here doing that. As you can see, if I thrust that way, it only takes care of one plane of motion, and that is the rotation, okay? So I wanna be as close as humanly possible to the spinous, but also getting the rotation out in the correct direction. So a PRI, I'm contacting the lamina, which is right there. Spinous, lamina. It's that close. Then when we would set it, we would come this way, come up and over the disc, okay? All right, and the last thing we're gonna go over is the cervical pull, which is a new topic for our club and a very more advanced idea. But this is what you'll be able to utilize when you have a severe torticollis patient. So when the patient is like this and they can't move their head at all, and you need to set this vertebra as a PLS, you're going to have to figure out a way to do that. And the patient isn't going to relax their head at all to get the proper head placement. So if it's a PLS like that, I'm going to have to do the cervical pull move. But what that entails is I'm going to use my right hand, but still be on the left inferior portion of the spinous and coming around like this, okay? So then when I'm doing the same movements as I can, but I'm still trying to lift P to A, I to S, and torque it back that way. So I'm using the patient's presentation to my advantage by doing the pull, but the corrective mechanism is going to be the exact same, except I'm using my other hand and reaching across. All right, so we're gonna go over something again. I know this is more of a fundamental topic. This is something that we very much overlook on the advanced side as well, is our patient placement. So as you can see right now, his arms are crossed, his feet are crossed, and they're back. All that does is just create a bunch of tension on the back of his spine. So what we're gonna do is tell all of our patients to sit on their heels with their feet up, just like that. Relax those legs, and then I want the hands, palms open, and placed right on their thighs, okay? So now he is in the proper position, and now his whole spine will relax. If you need to tell the difference when you're working with someone, have them do this and feel how much different and how much more tense this place is, okay? So this is the first way we're gonna start with our setup, is the patient's going to be completely neutral and with the hands up. We also, in the Gonstead cervical chair, we have this awesome thing called a strap. It's pretty much like a seatbelt. And when you have a seatbelt, you have extra stabilization, and that could be a reason why when we're young and starting, we can't get cervical chair because our stabilization is normally the #1 reason that is not doing the best. So utilizing this strap will add an extra point of stabilization that will make sure your patient is as stable as possible and you're not throwing them out of the chair. Okay, so if we're doing a PLI, a PRS, a PR, whenever our contact is on the right side, our stabilization goes over the left shoulder, okay, and then under the right arm. As you can see, I'm not choking him. This is nice and comfortable, and that's gonna be like that. So this strap always goes over the shoulder that my stabilization hand is on, okay? And now let's go into some of the quick setup parts of a cervical chair. So if I'm using a right contact, let's start with the PRS, okay? So I'm going to expose the spot that I'm going to contact. So let's say we're doing C7, all right? So it's always important for us to have the patient just ever so slightly look down, and we're standing back looking at this spot. I'm not up front here trying to feel it and just guess which one's C7 and try and get all my stuff while I'm up close. Okay, I'm stepping away, finding C7, tissue pulling past it, getting my fingers just like this and rolling it in and making sure my pinky's down and my fingers are in an I to S plane. Okay, so now once I'm at this step, this is when I step up to my patient. Now I'm going to step up, I'm going to relax him back and bring his head back to me. As you can see, his head is neutral. It's not flexed and it's not extended. His head is completely neutral to his body. I'm going to place my thumb right in front of the ear. I'm going to use my stabilization hand to be on the chin. For a PRS, this is something that's a little different in the Gonstead world compared to every other cervical chair, is that we are going to, for a PRS, bring his head in right rotation, right lateral flexion. The reason why this is if you look at the spine and look at the misalignment, PRS, as I rotate the head to the right, the spinous begins to come to the center. As I laterally flex to the right, the spinous also begins to come back to the position that we want it to be. So now my thrust is just ever so slightly. I don't have to bring the patient all the way over here like this and then just wham on them and hope that the bone rattles into place. We're very specifically placing the bone where we need to go, okay? So for a C7 or even T1, I'll do T2 right now. T2, PRS, this is all, come on back to me. This is all the head has to move. That's for T2, okay? So that T2 is locked out right now under my hand and I can feel it lock out. I did not need to initiate all the musculature and come here and rotate and then keep spinning his head off, okay? I can keep it very light, very easy, and make sure every patient enjoys cervical chair. The biggest reason why people don't like cervical chair is probably because they had it done wrong to them, okay? So don't be the doctor or the student that makes someone hate cervical chair because you're doing it incorrectly. So come on back to all the way here. We're gonna tissue pull, get our contact, bring the patient all the way back to neutral, and his head's in neutral, he's relaxed. We're gonna go to the right rotation, right lateral flexion, and then I'm going to set my chest ever so slightly on the back of his head. I'm not coming on top, I'm not doing nothing, I'm setting it ever so slightly right here on the back of the head. That adds an extra point of stabilization. Now my stabilization hand, I'm going to lift the thenar up, not just twist. I'm lifting the thenar up, placing it right under that, right near that jaw, and then I'm bringing my fingers back. And you can see my pointer finger is going down the SCM, then my third, fourth, and fifth fingers are coming around the SCM. This is making sure I'm keeping the whole cervical spine stable when I'm ready to adjust. Okay, so this is a spot right here. I could bring his chin ever so slightly to center, just that. And then when I'm ready to thrust, you can see for a C7, look at the angle of my arm. It is going I to S, and my stabilization arm is completely in the opposite direction. That's exactly what we want. So they come together. You can see his chin comes up because I'm coming together and I'm stabilizing the rest of the spine. Okay? For a PLI, I'm sorry, I'm on the lamina now. Same idea. I find that C7 spinous, tissue pull up and over, and then get my contact. That's the spinous right there. I'm on the lamina, which is right next to it. Same idea, bring his head back to neutral, right there. And instead of going right rotation, right lateral flexion like a PRS, for a PLI, the listing tells me PL, and then I is right lateral flexion. Stabilize, 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 as the good Dr. Wood says. We're still keeping our angle, I to S, everything is the same, except when we thrust now, we're coming through this I, and that's our line of drive. As opposed to the first one, we were coming more this way. The idea is always to set the body onto the center of the disc. All right, so now we're gonna show you a cervical pull on the patient. So as you can see, Steven's doing his best job to imitate someone with severe torticollis right now. And when this happens, the reason why I can't just, so let's just take this off right now, just to show you what it would be on the left. So if this was a PLS at C7 and I determined what's causing this torticollis and the patient couldn't move, we just showed how the head needs to be for a PLS. That means I need to rotate and laterally flex his head to the right. So if I tried to do this and the patient can't move from here, I can't laterally flex and rotate this head to the right. If I even did this, the patient would pretty much cry. Yeah, it's extremely painful. So that's why we have the cervical pull in our arsenal. So I'm gonna strap on this way because I'm going to come around. So for a PLS, with my right contact, I'm still tissue pulling on the left side around, and I am going to come and contact the left side of the spinous, keeping my fingers down, keeping this I to S plane, and making sure I'm correcting the PLS. Okay, so now I can come up to the patient, and they're not going to be able to move at all really, so they're pretty much staying here. So my stabilization is here, and when I'm thrusting, I'm just coming around and focusing more on the I to S, P to A, left to right. We can take care of the wedge on a different visit, but if you at least start to get some of the dimensions of the misalignment away, you will at least help the patient begin to next visit be able to be here. So if you do the pull on that first visit, you're not going to completely correct it by any means, but now the patient can be here. And then when the patient's there, we'll switch the stabilization strap. And then now we'll be able to do our PLS on this segment. So now we got the patient able to do this. And we're sitting here, and they come together, and the chin comes up, okay? One thing I also wanted to mention was our stabilization. If I'm doing C2 here as a PLS, look at how I to S my arm needs to be first of all to get over that displane line. And if I'm doing C2, I'm stabilizing much higher. I'm all the way up here to stabilize the segment and the segment below, and I'm offsetting and coming up. If I'm doing T2 now, look at how different my stabilization will be. If I'm doing T2, PLS, I'm now going to stabilize down here to stabilize that segment and the one below to make sure I'm not overdoing it. Okay? And you see how short those thrusts are and how quick they're got to be, but they're not by any means a big laterally flex, step to the side, throw the head that way. It's very, very short, sweet, and simple of being here. That's it. That's all it would take, just a little bit more and a little bit faster, and that would be the adjustment. All right, guys, well, thank you so much for watching us today. We have a fundamental video as well that will be in our YouTube channel that if you feel like we rush through any specific part of this that you need more slowed down, our fundamental video is there to help supplement with that. This was made for the advanced portion of the club that really dives deep into the more advanced, intricate parts that we see people that are older in school and really starting to get cervical chair down, making mistakes. So that's what this video was made for. So thank you guys for watching.
And make sure you guys check out the sheet as a reference. It has everything as far as this vertebrae symphyl correlations and different tips on setups and adjustments. So go check that out on Facebook and on Instagram as well.